Hello, my name is Kaye Reid Lombardo. I'm a surgeon at Mayo Clinic and practice in the field of liver and pancreas surgery. Today I'm joined by Dr. Flo Quay, an expert in the area of liver and pancreas surgery. Hello, Flo. How are you?
Fine, thank you, Kay. How are you?
Thank you for sitting with us today. We would like to ask you your expert opinion on neuroendocrine diseases of the pancreas and also about neuroendocrine diseases that has metastasized to the liver and the treatment of those two types of diseases. So Flo, can you explain to the audience if there are any risk factors for having neuroendocrine diseases of the pancreas?
Yes. For the most part, patients who present with neuroendocrine tumors of the pancreas have no known risk factors. There are some selected patients with MEN syndrome, which is a multiple endocrine neoplasia syndrome that can occur in families. And in that setting, those patients are at a higher risk of pancreatic neuroendocrine tumors.
And so how might those patients know that they have this disease? What are some of the symptoms that they might exhibit?
Any patient who presents with a pancreatic neuroendocrine tumor oftentimes has this tumor picked up because they develop some abdominal pain in the left side of their abdomen, in the upper abdomen, or they may develop symptoms related to the hormone production that these tumors can produce.
Hormone production, can you expound on that?
Yes, pancreatic neuroendocrine tumors can be either functioning or non-functioning tumors. The non-functioning tumors do not produce hormones, but the tumors that are functioning can produce insulin, glucagon, gastrin, for example, and then based on the hormone that's being produced, patients will develop symptoms from those hormones. So in the setting of a gastrin-producing tumor, they may have very aggressive ulcer disease of the stomach.
So this might explain why some patients may have ulcer disease that's not easily treated by over-the-counter medications, etc. This would be a way for patients to find out if they have a tumor located in or about their pancreas that may be causing this end result of having an ulcer.
Yes, so during the course of an evaluation for an ulcer, if a patient is found to be refractory disease, typically a gastrin level will be obtained. That's a blood test. And if the gastrin's high, then we start to proceed down the evaluation pathway for a gastrinoma.
And so if a patient presents to you in your clinic with a pancreatic neuroendocrine tumor, how are they evaluated?
The evaluation is multidisciplinary. That means that there is a team of physicians including a gastroenterologist as well as a surgeon, and sometimes an endocrinologist that evaluates the patient together.
So what are some of the tests that might be ordered to evaluate these patients?
The typical evaluation includes blood tests, a CAT scan, or an MRI. Sometimes these tumors can be quite small in the pancreas, so an endoscopic ultrasound, also called an EUS, may be obtained. And an EGD and EUS of the duodenum to look for tumors in that location as well.
So are all patients with this tumor eligible for surgery?
No. It really depends on local conditions. In this setting, local means if the tumor is involving the major vessels of the intestines, the root of the small intestine, or if the tumor has involved the blood supply to the liver, for example, and we're not able to remove it, then it may not be removed. Or if the tumor has spread throughout the abdomen, then surgery won't be indicated.
So what percentage of patients would you estimate are eligible for a pancreatic resection if they have this tumor in the pancreas?
Well, it depends on if we're speaking about patients who have disease limited to the pancreas versus those patients who have metastatic disease involving the liver. So for patients who have tumor limited to the pancreas, the majority of those patients tend to be resectable. And even if the tumor has spread to the liver, most times we will still attempt resection even if it's only to reduce the amount of disease present, which is called cytoreductive surgery.
And so I want to focus right now on how you approach tumors in the pancreas. What are the options available?
So as I was mentioning earlier, a distal pancreatectomy for tumors in the distal pancreas, or a Whipple procedure for tumors in the head of the pancreas. And this can be combined with a liver resection for tumors that have also spread to the liver. So we can combine a pancreas resection and a liver resection at the same time.
So patients are still eligible for surgery if the tumor has spread from the pancreas to the liver.
For neuroendocrine tumors, yes.
I want to be sure that that message is clear. And now let's go to cytoreductive surgery or debulking surgery. What are the criteria that you use to evaluate patients who may need this operation?
Basically, when I am evaluating a patient, I'm using imaging, MRI or CT, and I'm checking to make sure that I have 2 segments of the 8 segments of the liver that are located close together in continuity, and that these 2 segments that at a minimum I can leave behind are relatively free of disease. And so it's not just about how much disease I remove, but also about how much disease I'm leaving behind. In general, I try to aim for at least 90% of the tumor removed.
And this helps the patients how?
The cytoreductive surgery, what it does is it sets the patient back on their timeline or the natural history of the course of the disease. So by removing that tumor burden, we set the patient back a few years in the course of their normal disease process.
And so if patients have disease in all 8 segments, do you still consider cytoreductive surgery as an option?
We can still consider it if the amount of disease is minimal. However, if there is so much disease throughout the liver, another option would be transplant, a liver transplant.
Well, let's talk about that. What are some of the alternative therapies available at Mayo Clinic for patients who may have disease that has spread from the pancreas or elsewhere, that is neuroendocrine and etiology, to the liver? If surgical resection is not an option, are there other options available to them?
Well, as I had mentioned, there is transplantation, liver transplantation that can be performed for select patients. But we also have TheraSpheres, which is a radioactive agent that's placed within the liver and used to embolize the tumors. Embolization is where we cut off the blood supply to the tumor and try and use both a combination of embolization and chemotherapy to treat the disease. There's intrahepatic radiotherapy with radioactive beads that can be used as well. And then there are on the horizon some chemotherapeutic agents that we're now studying to see if we can use those medications to check the disease, to keep it in check.
So there are potential clinical trials that these patients may become a part of if they're evaluated here and deemed eligible.
Yes, we have a few ongoing trials currently.
Can you describe some of those trials?
Reid 001 is a rapamycin-based drug. It's an mTOR inhibitor. It was initially used for immunosuppressive therapy for liver transplants. And it has been found to be useful in the treatment of neuroendocrine tumors. And now that's one of our protocols that we have ongoing.
And I want to talk a little bit more about surgery as an option for this. What are some of the short-term complications that might occur after this operation? And then would you comment on the long-term prognosis if they do get this cytoreductive surgery?
So for cytoreductive surgery, which is resection in the liver or of the liver of disease that has spread from the pancreas to the liver, the risks of surgery, depending on whether or not we're removing the pancreas at the same time or a portion of the pancreas, the risks can include a leak from the parenchyma of the pancreas, so the tissue of the pancreas, because there's many ducts in the pancreas that deliver enzymes to the intestine, and these can leak. The leak rates somewhere between 10 and 20%, whether it be done open or laparoscopically. The other risks from the liver resection end of things also includes a leak, because the liver has a biliary tree within it, and the biliary tree has many branches, and these can leak bile. The risk of a leak usually after this type of resection is somewhere around 3%.
So it's a very safe operation that can be performed. And can you speak to the experience of Mayo Clinic and you and your colleagues in treating this disease?
Mayo has a tremendous wealth of experience in the treatment of this disease. We have published on over 200 patients having had liver resection for metastatic neuroendocrine tumor, whether it be from the small intestine that has spread to the liver or from the pancreas that has spread to the liver. And we have followed the survival of these patients over time and found that this is an effective treatment in both prolonging these patients' lives, but also in improving their quality of life.
So debulking, I'm hitting the point that debulking is important because in the literature there are some papers that do not support debulking, and perhaps some people do not support debulking in the country. But your experience lends to the fact that the prognosis is quite good, both short-term and long-term, and so these patients should be considered for a debulking operation.
Yes, it can be a little bit controversial, but I would say if you review the literature, you're going to find that for the most part there's support for this aggressive approach.
Now, why should a patient come to Mayo Clinic for the management of this disease?
It's a rare disease, and for the vast majority of clinicians that are out practicing, seeing a patient with neuroendocrine tumors may happen once in their career. At Mayo, we see patients with this disease every week. In fact, some of us see patients with this disease every day. And it is not unusual at all for me to have a patient with this disease on my schedule from week to week.
And so they should have the expertise, and that is available here. Mm-hmm. Anything else you want to add about the treatment of disease? Any new treatments on the horizon that may be offered to patients?
The octreotide therapy that's currently standard of care for patients with hormonal symptoms related to this disease is continuing to evolve as well, and newer versions of this drug are coming.
So are there any chemotherapies to treat this disease?
Not as a standard of care at this time, no. So that if patients want to look at chemotherapy for treatment of this disease, then they most likely would end up being enrolled in a study. Or if they're having severe symptoms related to their disease, they may get treatment that would address those symptoms, but not necessarily be considered standard of care.
So to recap, neuroendocrine tumors can originate in or around the pancreas, in the small bowel, and that disease then can spread to the liver. However, you recommend an aggressive approach to these lesions, and that patients should be evaluated for potential surgical resections. When in this timeline should primary care physicians or referring physicians refer patients to Mayo Clinic to evaluate these patients?
Given the rarity of the disease and the lack of expertise in the medical profession for physicians that are not in a tertiary care center, I would say whenever they have a diagnosis of a neuroendocrine tumor and they're considering surgery for treatment of that disease, they should refer the patient to Mayo or a tertiary care center.
Well, thank you, Dr. Quay, for joining us. I'd like to give you the opportunity to add any ending and supportive comments to what you've said. Is there anything else you'd like to add?
Well, neuroendocrine tumors are a very slow-growing tumor, and it's important for the patients to realize that they can live for many years after they've been diagnosed, even in the setting of metastatic disease in the liver. And so they should come for evaluation because there may be something that can be done for them.
Dr. Quay, thank you for joining us in discussing pancreatic and metastatic neuroendocrine tumors.
My pleasure.
And thank you for joining us. This is Dr. Kaye Reid Lombardo from Mayo Clinic. Yes, this is great. I'm glad it's finished. Tell Sylvie.